important for me, and maybe it was just forgotten in the title of the presentation. My disclosures. You have seen this already, but I'm very happy to show it again because these people and all the experts that contributed really deserve to be mentioned here because it was really a great team effort. So the PEEP recruitment maneuver domain was domain number 6. It was led by Jeremy Beitler and the past president of our society, Joseph Kesesioglu. And these are the trials that have been analyzed and then finally selected. As you can see, for the first PICO, which was the comparison between high and low PEEP level, we selected 3 trials that are the alveoli trial, the LOVES trial, and the EXPRESS trial. And these 3 trials were considered sufficiently homogeneous to be meta-analyzed, despite the differences in the study design, because basically, especially from the high PEEP was different in the alveoli and in the LOVES study. They used the high PEEP FiO2 table, while in the EXPRESS study, as you know, the PEEP was the highest level that the PEEP was increased up to reach a plateau pressure of 30. And also the control intervention was different among the trials, but still, again, we decided to meta-analyze these studies together, and this is the results. So the PICO was in patients with ARDS does routine PEEP titration using a higher PEEP FiO2 strategy compared to a lower PEEP FiO2 strategy, reduced mortality. And I underlined the word strategy just to highlight the fact that, again, these studies used different strategies to titrate PEEP, and so different levels of high and low PEEP. And the conclusion was that we were unable to make a recommendation for or against routine PEEP titration with a higher PEEP FiO2 strategy versus lower PEEP FiO2 strategy to reduce mortality. So mortality was our primary outcome. Another primary outcome were ventilator-free days, but these were not meta-analyzed because they were not provided in one trial. And the other 2 trials gave conflicting results. So we do not have any idea about the effect of higher versus lower PEEP strategy on ventilator-free days. Among the secondary outcomes, we analyzed the risk of barotrauma, and what we saw was that there was a strong evidence of absence of increased risk of barotrauma due to the high PEEP approach. So as you all know, the same 3 studies had been meta-analyzed in a very important paper published in JAMA in 2010 by Brill. And they basically had the same conclusion when they pulled the 3 studies together. But what they also performed this subset analysis, subdividing patients with what was called at that time ALI, so PF ratio between 200 and 300, and what was probably called ARDS, so PF ratio below 200. And what they saw was that there was a significant advantage in terms of mortality for high PEEP approach in patients with ARDS, so with a lower PF ratio. In our group, the panel decided not to perform this sort of sub-analysis, so we only issued the recommendation that I showed you. But as you know, there are evidences like this, and also analysis from the subphenotype approach proposed by Caroline that show that patients with more severe disease, patients in the hyperinflammatory phenotype may benefit from higher levels of PEEP. But what we found from the meta-analysis of the 3 randomized control trials was no recommendation, basically. The second PICO question was, in patients with ARDS, does routine PEEP titration based principally on respiratory mechanics compared to PEEP titration based principally on a standardized PEEP FiO2 table reduce mortality? So we decided to include in this analysis, after a long discussion, the two studies on esophageal pressure, so the study DAP event 1 and 2. Then there was a small study by Pintado that has a design which is similar to that of Cavalcanti, so an open lung approach, and we decided to include in this category also the ART trial. So this was discussed, because as you will see, the ART trial is also included in the meta-analysis on recruitment maneuvers, but we reasoned that the design of the ART trial, so the open lung approach, is a way to set PEEP according to the highest respiratory system compliance. So we decided to put these studies together, and as you can see there, there was no evidence for or against the use of PEEP titration guided principally by respiratory mechanics to reduce mortality in ARDS. And like all the other recommendations, we applied the same recommendation to COVID-19 with a downgraded level of evidence for indirectness. Then we go to recruitment maneuvers. It is very difficult to study the effect of recruitment maneuvers separately from the effect of PEEP. Indeed, all the studies that are listed there, all of them assessed the value of the addition of recruitment maneuver to a higher or lower PEEP strategy. So again, it's difficult to separate the effect. But as you can see, we included in the meta-analysis again the ART trial, the study by Cavalcanti, and the studies were subdivided in low or very low quality versus moderate high quality. As was said by Karen, we decided to include in the primary analysis only the studies with high, moderate quality of evidence, and so basically all the evidence comes from the ART trial. And due to safety concerns, we decided to issue a strong recommendation against the use of prolonged high-pressure recruitment maneuvers. And we decided to subdivide recruitment maneuvers in prolonged or short. And prolonged were defined as airway pressure maintained above 35 centimeters of water of pressure for at least 1 minute, to reduce mortality, again, due to safety concerns, because of the increased risk of barotrauma. And as you know, in the ART trial, also some patients had cardiac arrest during the stepwise recruitment maneuvers. We also decided to study the effect of short recruitment maneuvers, so same level of airway pressure, but maintained for less than 1 minute. So we included these two studies. The study by Lorraine Mead is the LOVES study that was already included in the tidal volume analysis. And we issued a suggestion against the routine use of brief, high-pressure recruitment maneuvers to reduce mortality. So, and I underline the word routine. If we compare our recommendations to the 2017 guidelines, there is a huge change, because in the 2017 recruitment maneuvers were suggested, while, as you can see there, we basically issue recommendations or suggestions against the use of the routine use of recruitment maneuvers. Of course, there are resource gaps that need to be assessed. Well, the first one is how to best individualize PEEP setting. Do we need a recruitability test to select patients with higher potential for lung recruitment? What is the exact role of esophageal pressure-guided PEEP setting? And of course, we don't know what is the exact benefit in terms of patient outcome of the application of brief recruitment maneuvers as periodic psychs. Then, as I told you, I want to tell you something about prone positioning. The first PICO is whether prone position reduces mortality in patients with ARDS. And as you can see there, we consider the number of trials. And if you pull together all those trials, you don't see an effect on mortality. But we decided to base our recommendation on the results of the PROSEVA trial, because all the other trials were done in different periods, so not in all of them protective ventilation was mandatory. They applied prone positioning in different periods of the disease and for different duration of the pronation sessions. So we decided that the ProSEVA trial, and I understand that this is a bit can be debated, but the ProSEVA trial is the major source of evidence, and from this comes the strong recommendation in favor of the use of prone positioning according to the ProSEVA trials criteria, so PF ratio below 150, PEEP above 5, to reduce mortality. And this applies also to COVID-19. That's why we do not have randomized studies in COVID patients. We also asked the question when prone positioning should be started, and again, we suggest to start, we recommend to start prone positioning according to the ProSEVA criteria. And what is very important, we also propose and recommend to continue prone positioning even if there is no improvement in oxygenation during the proning session. And this comes from, for example, this study. This is a secondary analysis of the ProSEVA trial published in the Blue Journal that shows that the effect on oxygenation, so the increase in PF ratio after prone positioning, is not necessarily associated with the improvement in survival, which means that not all the patients who benefit from prone positioning in terms of mortality are those who have the most benefit in terms of increase in PF ratio. So we strongly believe that prone positioning should be continued unless the patient deteriorates, irrespective of the response in PF ratio. We also assessed the role of awake prone positioning. As you know, this has been used only in COVID patients, and we ended up with a suggestion, so a awake recommendation in favor of the use of awake prone positioning in non-intubated patients treated with high-flow nasal cannula. And this is because in all the randomized studies that we meta-analyzed, the control group was mostly treated with high flow. And of course, we were unable to make a recommendation for or against the use of awake prone positioning in non-COVID ARDS because there are no studies in non-COVID ARDS. And also here, there are research gaps. So how do we define the response to prone positioning? What is the optimal duration of the prone positioning sessions? When should we stop prone positioning? And of course, the effect of awake prone positioning in non-COVID patients, and should we apply awake prone positioning outside the ICU? Finally, the ECMO extracorporeal CO2 removal domain. You can see there the number of studies that have been analyzed and finally selected for the meta-analysis. For the ECMO, there are two randomized control studies, the CESAR trial and the EOLIA trial. As you know, the CESAR trial was the first randomized control study that showed a significant benefit in terms of mortality for patients who were allocated to centers with the capability to provide ECMO. So not all the patients randomized to ECMO actually received ECMO. So the CESAR trial more convincingly shows that it's important to transfer patients to a center that has the ability to give ECMO, which means that it's probably a center with a greater expertise in the management of ARDS. The EOLIA trial has been published in the New England Journal of Medicine. As you know, the P of the EOLIA trial was 0.07, 11% absolute difference in mortality. So the conclusion in the abstract of the New England is that that ECMO does not make a difference compared to standard treatment. As you know, there was a lot of crossover. Then there was the Bayesian analysis published by Johan Golliger, and in the end, the panel was convinced that the evidence is strong enough to recommend the use of ECMO in patients with severe ARDS as defined by the EOLIA trial eligibility criteria. And this is a difference between compared to 2017 guidelines where there was insufficient evidence to recommend ECMO. While for extracorporeal CO2 removal, well, there are, two studies, the EXTRAVENT study published by Bain and the REST study by the group of Danny McCauley. There is no difference in mortality, but there is a concern, a safety concern, because in the REST trial, there was a significantly higher number of severe side effects attributable to extracorporeal CO2 removal, in particular hemorrhage. And so, in the end, we produced a recommendation against the use of extracorporeal CO2 removal to reduce mortality in ARDS, not due to COVID, outside randomized controlled trials. So this was my last slide, and before closing, let me thank the Society for the opportunity to chair this process. It's been a great experience, and thanks to Caroline and Luigi, my co-chairs, and to all the experts. Thank you very much.